So we'll start. The first topic is by Dr. JAINY Joseph, and she is working as a glaucoma consultant at Amala Medical College, and she will be speaking on ASOCT or UBM, the which and the why. Over to you.
Very good afternoon to all. At the outset, I would like to thank KSOS and Dr. Jayasri for giving me this opportunity. My role is actually to introduce the two devices, ASOCT and UBM, and their specific indications. So I have no any financial disclosures. So when I search the literature, actually there are so much literature articles regarding which and when to use. And actually, it's not a big debate to think about which device to use and when, because both are actually acting with different mechanism and both are having different indications, both are having different uses. So it's not a big debate. You should know the proper condition and you should use it properly. So both ASOCT and UBM are non-invasive imaging devices which gives the high resolution cross-sectional images of the anterior segment of the eye. So regarding UBM, it is mainly uses the high frequency ultrasound, and it actually requires a water cup bath setup. There, whether it's a liquid media should be there between the probe and the eye, and hence it takes more faster. It takes a longer time to acquire the images, and it is usually a trained technician is required for its operation. But the unique feature of this UBM when compared to the ASOCT is that it can capture through the opaque media, the opaque cornea, and we can visualize the structures behind the iris and the ciliary body, which is not visualized by the ASOCT. Whereas ASOCT is using the light waves and it acts on the principle of low coherence interferometry. And it is a non-contact technique, and it gives us faster acquisition of the images. But the problem with ASOCT is that it requires a clear media and we can't visualize the structures posterior to the iris pigment epithelium. So when should I go for a UBM? The first thing is when the cornea is hazy, I have no other options, it is only UBM. Like conditions in which there's the corneal opacity, a case of congenital glaucoma or a Peters anomaly, where UBM will help us it may reveal the presence of any associated aniridia or a congenital aphakia, and it may also help in the proper surgical decisions in the management of those patients. So it's the imaging modality of choice is UBM. If you want to visualize the structures behind the iris and the ciliary body, the imaging modality of choice is UBM. The thing is that if I can use an ASOCT to find out whether the angle is open or not. But still again, if I want to know the mechanism of the angle closure, or if I want to rule out the plateau iris, I should go for a UBM. Because the plateau iris is mainly due to the rotation of the anterior ciliary processes, and I should see whether the ciliary sulcus is present or not. In those cases, UBM will help us. Also in conditions like pseudo-plateau iris, in which where the iris cyst or can be due to secondary or iridociliary tumors, which can cause pseudo-plateau iris, those mechanisms also will be relieved by the UBM. Then to visualize the zonules and the peripheral lens, as in case of post-op patients in which the patient comes with recurrent redness and pain, uveitis, in those cases we can look for the malpositioned IOLs and the presence of CTR, the positioning of CTR with the lens, all can be evaluated by the UBM. Also in evaluation of phakic IOL patients, UBM also plays an important role. Then in case of malignant glaucoma, the anterotated ciliary body can be well visualized with the UBM. In conditions in which a young patient can present with an acute onset transient myopia with bilateral angle closure, which can be due to drug-induced, the supraciliary effusion can be well visualized with this UBM. Also in post-traumatic cases and in post-op, post-trabeculectomy, the ciliocoroidal detachments, post-laser, all is better visualized with the UBM. But in patients with anterior segment trauma or a suspected case of open globe injury and all, the imaging modality of choice will be ASOCT, because immediately post-op bleb assessment is all better with this non-contact technique of ASOCT. And the positioning of the glaucoma drainage devices all can be immediately assessed by ASOCT due to its non-contact nature. But still, post-traumatic, still the patient is having prolonged hypotony and all. We can assess the presence of cyclodialysis cleft. It is done by it gives seen only by the UBM. Also, the presence of angle recession can be clearly assessed by UBM. But if we are sitting at an OPD, yes, you want to go for a routine quick angle assessment. We have no trained technician is not there, or the patient is slightly uncooperative. Better go for an easier technique like an ASOCT. The other advantages of this ASOCT is that the non-pigmented tumors are better visualized by the ASOCT. Also, in case of this OSSN, the intralesional details can be better evaluated by ASOCT, and the proper management can be decided by it. Whereas UBM plays an important role in pigmented tumors, and the delineation of the posterior margin is better visualized by UBM. So the ASOCT is a non-invasive, non-contact. Other one is the contact method. The ease of operation, better, easily done. ASOCT, other one requires a trained personnel. ASOCT can be done in a sitting posture. UBM, initially supine, but now it is available. The patient can be done in a sitting posture. But the thing is that in anterior segment, only till the iris pigment epithelium is visualized in ASOCT, whereas in UBM, everything posteriorly can be visualized till the iridocerebellar complex can be visualized. Both has its own limitations, no view in opaque cornea, and the sclerals by definition problem is still there in ASOCT. UBM, again the risk of infection, corneal abrasion due to its contact nature, and is contraindicated in suspected open globe injuries. So I will conclude it that actually the other sections will enlighten you about more about these devices. So my conclusion is that both complement each other, each has its own uses and its own limitations, but still the dynamic indentation gonioscopy is still our clinical reference standard method, and these tools and all will augment our practice and helps in research. Thank you.
Thank you, Dr. Jaini, for highlighting the situations where you can use UBM or